Okay. All right. I think I'm recording. Did you all get a notice that it's recording? Fantastic. All right. Well, we'll get started. Welcome, everyone. Thanks so much for joining today to hear about the PRIS Network. Um, I am Suni Kaiser, the current chair of the network. I'm a pediatric hospitalist based at the University of California in San Francisco. And we just wanted to use this opportunity after having a workshop and speaking with folks at the summer PHM conference to follow up with some more details for those who weren't there or folks who want some more follow-up information about the network and how it can benefit you and how to get involved. Um, our mission as a network is to improve the health of and healthcare delivery to hospitalized children and their families, really through focusing on supporting the conduct of large multi-institutional studies. And we want those studies to be relevant and prioritized by clinicians and families to help navigate the decisions they face in care. And we were founded quite a while ago now, back in 2001, as a small group that's really expanded over time, aligned with the expansion of the field at large and our research capacity. We have hospitals that are members renew and confirm their membership every couple of years. And we hover right around 100 sites that span both the US and Canada. The majority are children's hospitals, but we do have a contingent of community hospitals that participate as well. And one thing that makes Prize unique compared.
Suni,
Oh,
sorry to interrupt
oh
you.
yeah.
Your slides aren't advancing for some reason,
Oh,
at
all
least
right.
the
Okay.
screen that you're showing. Sorry.
Thank you. No, thank you for telling me. Um, is
Yep,
it?
now they're good.
Oh, fantastic. Great. I paused the recording. I thought I paused recording and instead I paused slides. Okay. Thank you. Thank you. Okay. So that was the mission, which I read aloud to you all. And this is sort of our quick stats. So again, founded in 2001, about 100 sites. And then one thing that makes us unique is that we have no participation fees for individual members or institutions. We fund our work of supporting research really through kind of fee for service. Model through a variety of services we provide specifically to support research, which I'll go through in more detail. But to sign up, to be on our listserv, to hear about what's going on and consider participation, there's no fee at all. Okay. So in terms of our leadership, I mentioned I am current chair of the network. Dr. Kathy Auger will be joining shortly, and she is vice chair. She and I together oversee kind of overall network operations. And then I believe Dr. Chris Russell is on here as well. He oversees engagement, sort of thinking about how we engage with and meet the needs of current members, how we expand our membership to support others. And then Dr. Matt Brady is on as well, and he oversees our scientific kind of operations, which really center mainly around supporting folks that want to do research through the network. And I'll talk a little bit more in detail about how to access that process and those fees. You'll see several other folks from our leadership on the call as well. So you may recognize folks from your institutions as well, but Steph Dubnik, Joanna Lionar, Derek Williams, Eric Kuhn, Kavitha Parikh, Mike Chu, Katie Forster, I think Matt Pantel is here, Elisa Khan. I mentioned Chris Russell already, Lilian Ambrosio, Michelle Kelly, Amanda Schondelmeyer, Hallie Rupel and Jen Rosenthal. So really spanning across the US, and these are folks that are really physician scientists that are leading extramurally funded work. And we, through the network, really support each other in that work and try to expand the reach, using the network's resources of our efforts as well. So, what does the network do, and how can you benefit? So, we do a variety of networking and educational events. So, I mentioned at the PHM conference this past summer, we did an event for trainees and junior faculty that are exploring doing research and research careers, to better understand what that looks like, plan next steps, and meet people who might be mentors or collaborators for that work. So that might be a great opportunity when folks are already at a conference and interested in research to join these events, again, within your division or your institution. And the way to find out about those would just be to join our listserv to hear about them. Um, we do periodic webinars, just in this format, Zoom free, that we again share on the listserv. And we do a combination of sharing about work that's come out of the network, like some of the survey studies that are conducted or some of the bigger trials that folks are working on. But we always try to combine that with a little bit of how to, in terms of, how you could apply that to work you're doing locally or explore new projects locally. We also provide specific support for people to conduct research. So through the listserv, we will send out opportunities for studies people are leading but need sites and site PIs. And then we also advertise and sort of link you to our research support services. And then by participating to gain skills to lead your own work locally or to support prize studies. Really, the goal here is to contribute more broadly to the network's work of generating greater evidence to guide our care. Across really a wide variety of topics from basic to translational to health services and equity focused work that folks are doing. So I've mentioned a couple times it's free to join, and we just need your email to add you to our listserv. If you go to our website, prizenetwork.org, this is the landing page, and there's a button to give us your information to join the listserv, which of course you can leave at any time. We really do try to limit the amount of communication to folks on the listserv, knowing that everybody gets too much email. So we limit any survey studies that we're conducting through the network to about three, max four a year. And other sort of announcements, again, really don't exceed more than like once a month, if even that. Regarding, again, these kind of educational opportunities or networking events, as well as the surveys. And just to be clear, the survey studies we do just go to the site leaders at participating institutions, not kind of the larger listserv. So the larger listserv just gets opportunities. Um, these are some of the grant and research support services I was mentioning that folks can access for a range of fees from smaller to larger. The most common support people seek from PRIS is conducting a survey. So I mentioned we have access to site leaders at about 100 hospitals across the country. And so we have a denominator defined if you want to conduct a survey to better understand any topic you're interested in. This usually falls in the category of kind of health services, resources, and how things work right now. So um, I personally, conducted a survey years ago about whether hospitals in PRIS had asthma clinical pathways in place and what that looked like when they were implemented, things like that. to understand kind of the current state of care quality infrastructure around that topic. And that can be a nice building point or starting point to build, other research and other questions that could be helpful to improve care and outcomes for kids in the hospital setting. But we've done surveys across a whole gamut of things. From language equity to immunizations in the hospital to social risks and social risk screening. And again, this is a good starting point. The fee for a survey study is pretty small, I think $1,000 to $2,000, and we also do some considerations around trainees for that work. And submitting an idea for doing a survey is very brief. It's just kind of like a one-page form and then a draft of your survey. So that's a really easy way to get in the door to conduct a study of that type. If you are writing a larger grant, an extramural grant, I guess large or small, it's often helpful to show funders that other people, including national organizations, think that topic is important to study and the way you're proposing to study it is sound. And so the network will often write letters of support that relay those points to help people get funded. And then for larger grants that need more support, we also offer a variety of services from a large group feedback session to more detailed sort of actual review of your writing and your grant components. We can help recruit sites if you're proposing a multi-site study. And then once you're conducting the research, we can also help with advisory kind of capacity, data safety monitoring boards, and dissemination. So on the website, PRIS network.org, there is a link to that there is a link to kind of submit your research idea. And within that brief survey, you can specify what kind of support across these different entities that you're seeking from the network. And then also link to the associated fees, which again range from smaller to a bit larger. I see some folks already chatting like, is my hospital in prize, et cetera. So you can do that in real time in the chat and have Lisa sort of looking it up. But you can also email her. We would love if your hospital's not a site and you're interested again for you to join and be our site contact, which is free. But if your site is already participating, you can join as an individual again, just to join the listserv and get communications about networking events, educational sessions, and upcoming studies. So with that, I'm going to pivot to um, from talking about the network as a whole to some of the active research we've are working on right now, and been working on the last couple of years. And I'll kick off with this, which I apologize, came out a little blurry on transfer, but over the last few years, we led Eric Kuhn, who's here on the call, and I led with a great group of folks from around the country an exercise of trying to prioritize what the most important clinical trials were to conduct in the field of pediatric hospital medicine. So we started with a review of the guidelines, evidence-based guidelines for the top conditions we care for in PHM, things like asthma, pneumonia, et cetera, to pinpoint important gaps in our knowledge for diagnosing and managing those conditions. And then we had small groups work on generating kind of what RCT specific questions would fill those gaps. And this was a group of about 50 people. that then engaged in prioritizing those questions based on importance for impact for child health and feasibility. And we also put that workout or that ranking out all in national listservs for people to weigh in on as well. And ultimately came up with a long list of questions, but the top 10 of them are here. And again, I apologize for the blurriness, but the big takeaways are that a lot focus on optimizing antibiotic treatment for common infections like cellulitis, pneumonia, and urinary tract infection. There are some questions around steroids, systemic steroids in asthma, hydration and gastroenteritis, and management of fever in young infants. And as a network, we've worked in, really trying to support conduct of these trials and have some of them ongoing, some of them pending kind of funding assessment as well. So this is really exciting. Uh, and then I'll turn it over to Eric to talk about Fancy.
Thanks, Suni. Yes, the FANCY trial focuses on post-hospitalization follow-up, which I think is one of the most common interventions that hospitalists prescribe to children. Um, There are many intuitive reasons why we do it, and historically have done it for most children. It's an opportunity to check in with the PCP, make sure a child's getting better the way we think that they will. But I think we often don't reflect on some of the burden that we're putting on families when we prescribe automatic follow-up. They have to miss more work, miss school. There's expenses like co-pays and transportation costs, a risk of overtreatment. So Fancy is really trying to figure out, should we be prescribing automatic or as needed follow-up? Next slide. For four conditions in particular, urinary tract infection, pneumonia, gastroenteritis, and soft tissue infection. And our primary outcome is hospital readmission within 14 days of discharge. We're looking at lots of other secondary and exploratory outcomes like quality of life and the medical interventions that children receive after discharge. This trial is in its fourth year. We've randomized now about like 2,400 children across 14 PRIS hospitals, which is really awesome. We're ahead of schedule and probably going to finish enrollment in January or February, supported by the Patient-Centered Outcomes Research Institute.
Great, Eric. I think is Pat here? Pat, do you want to talk about emo? If not, I can, but just to move.
Sure, I'll do my best. Nothing like a simple cluster randomized implementation study to talk about. But with Amanda Schondelmeyer, Chris Landrigan, and a bunch of prize members, I'm a co-investigator with Chris Bonafide and Renad Beatus-led EMO study. This is funded by the NHLBI and also in its final year. So this is work to take a problem that hospitalists have been working on and complaining about for a decade plus now, that we overuse pulse oximetry quite a bit in particularly babies that are already improving and on room air. So what EMO did, as you can see a little bit in that bottom left figure, is recruit 50 prize hospitals to measure baseline overuse in the first years. This was research coordinators or site investigators figuring out who we're monitoring. Then they were randomized at the site level with the idea that we balance them based on community versus academic and baseline overuse and a couple other covariates. And then hospitals received either educational outreach and audit and feedback. So relatively usual. We're going to go to a nursing meeting and walk through some PowerPoint slides on why we shouldn't do this and who says we shouldn't do it, and then share some data. And then folks randomized to the other arm got that plus deliberate work with informatics experts where they helped build new EHR tools. And then uh, year three, which was um, a couple years ago now, COVID made traditional bronchiolitis season a lot of fun, but thanks all for adopting. We withdrew the education and audit and feedback, but kept the clinical decision support in place and measured sustainment with the hypothesis that um, uh, hospitals that were randomized to the decision support would ultimately have more sustainment of the benefits. The results that was shared at the PHM plenary this summer didn't show that, somewhat surprisingly. So one can see going from P1 to P2, both arms got better about the same amount. That is exactly what Chris and Renad predicted. But what you also see is that those numbers in the third year are pretty similar as well. So there's some interesting work the team has done around how baseline decision support. So you can imagine a lot of hospitals had some tools that helped in P1, might have better predicted this, but a great study and one that led to some important knowledge, as well as another IMPSI study that I think Eric will be talking about in a little bit.
Great. Thank you, Pat, for that last minute um, takeover of that content. I don't see Joanna here, so I will go over eye care. And this is was really born out of her interest in kind of the growing mental health crisis we face in, all healthcare settings and at large, but specifically in the hospital, having a lot of children in mental health crisis that are just boarding while waiting transfer to sort of more definitive care in inpatient psychiatric facilities, which are limited in availability. Um, so their team developed a digital intervention to teach some foundational psychosocial skills during this waiting period that sort of non-mental health trained personnel could deliver to children and their families. Their primary outcome was evaluating changes in emotional distress and suicide risk. And they were also assessing relationships of changes with sort of the mechanisms they felt like would lead to changes in that outcome. So things like coping, hope, and treatment engagement. So some of the participant data is below. It was involving youth aged 12 to 17 years with suicidality, took place in two EDs, one children's hospital and one general hospital. Um, there's sort of a mini kind of consort diagram at the bottom left, showing kind of the patient flow through the study. Kids were around 16 years old, predominantly Medicaid insured, and completed between 4 and 5 of these modules, stayed in the hospital an average of 78 hours. And then they found that their suicide risk with engagement with the tool decreased, as well as their emotional distress. Um, they they did, again, I think on the bottom left is some of this kind of mediation they explored of um, how much hope or treatment expectancy, readiness to change, or coping skills may have been related to those outcomes. And overall, this study is sort of in wrap up and dissemination phase. It was also funded by the Patient-Centered Outcomes Research Institute. So this is a flyer that is meant to be sort of more public facing in terms of explaining their results. Um, so this is Dr. Liner's work in this space. And then I'm going to hand it back to Eric for I Decide.
Thanks, Suni. So iDecide is in the first year of a 5-year grant, so at the very beginning. And this also focuses on post-hospitalization follow-up, but specifically for kids who are hospitalized with bronchiolitis, where there's randomized trial evidence, um, AEP textbooks, just kind of robust evidence suggesting that as needed follow-up is a very reasonable default practice in this population. Yet, despite that evidence, we're still doing a lot of automatic follow-up in this population across the country. This trial is involving, at least at the kind of, we're reaching out to about 70 PRIS hospitals. It'll end up being less than that. And I do want to say there's tons of you on this call who are, trying to get your sites up and running for iDecide, and we really appreciate all of your hard work. And as it says here, I'm working on this project, but Chris Bonafide is the other PI. Next slide, please. And so while Fancy is like directly comparing as needed and automatic follow-up in those other populations to really see like which one is a better strategy, here we're trying to disseminate as needed follow-up for kids with bronchiolitis across the country, across all the hospitals that are participating. And really the scientific question is an implementation science question. What is the resource input that's required to change practice in this space? Can we do just kind of a moderate amount of resources like traditional QI methods, or do we need higher resources to really move the needle? And so that's what's being compared here. It's a cluster randomized trial, very, very similar design to the EMO trial that Pat presented on a few slides ago. So half the hospitals get randomized to moderate resource implementation strategies, which are educational outreach, audit and feedback, and some clinical decision support materials. And then half of the hospitals in iDecide get randomized to high resource implementation strategies, which are all of those moderate resources plus some facilitation to, again, see if higher resources can really, in this case, increase as needed follow-up prescribing and decrease unnecessary follow-up visit attendance by families for kids hospitalized with bronchiolitis. Also funded by Patient-Centered Outcomes Research Institute or PCORI.
Great, thank you. And then this next trial is one that I am running based at UCSF. I also see some site leads for the SIP trial here. Thank you for all your hard work, and we are through it now. I presented this work at the PAS conference, but the SIP trial, the heart of what we were trying to answer here was if community and more sort of general hospitals could effectively implement a bundle of clinical pathways in sort of a higher efficiency way, the way kind of larger children's hospitals like Seattle, CHOP are doing, and do that effectively. So we implemented a bundle of clinical pathways around respiratory illness care, asthma, pneumonia, and bronchiolitis pathways. Um, this was also a cluster randomized trial, and I just have deep, deep appreciation for the hospitals in our control group who waited 2 full years to get this intervention, but made for like a really, really sound trial design. And they all got it last year and are almost done implementing as well. But we had 43 hospitals randomized to either start implementing these pathways or wait and get them later. We had a total of 7 evidence-based practices that we were focused on improving with the implementation of the pathways, using standardized protocols or pathways to guide titration of albuterol, early use of metered dose inhalers in the hospital, prescription of inhaled corticosteroids for kids with asthma over the age of 5 before they were discharged home. For pneumonia, using narrow spectrum antibiotics and avoiding macrolide prescription at discharge. And then for bronchiolitis, avoiding chest x-rays and albuterol use. This is an analysis where we looked at their adherence before implementing the intervention and how much it changed or the difference over the 2-year period in our intervention hospitals, which is kind of the first column of percentages there. And then we looked at that same change in our control hospitals. And our primary outcome was just mean adherence to these practices as a whole across all 7 of them. For which we saw about an 8% increase in our intervention group and a 4% decrease in our control group. So our overall effect size was about 11% increase in adherence to these evidence-based practices. To frame, the mean adherence was around 60%, looking across all of them, varying from 30 to 70, depending on which one we're looking at. So we were really excited to see that community hospitals were able to, with some of the core strategies that have been discussed here a lot, like education and audit and feedback and coaching, achieve this sort of higher efficiency approach to QI. We are also just this morning going over some subgroup results, and we found that non-teaching hospitals and true like community sites had the greatest benefit. So I'm very excited about this, and thank you again to those on the call that have helped with this work. And then I don't think Elisa is on the call. Elisa Khan is leading this work called iPass Listen. This builds on prior work with the iPass sort of handoff work and family-centered iPass. And it is also funded by the Patient-Centered Outcomes Research Institute. It's an RCT of a family-centered rounds intervention that is specifically focused on hospitalized patients and families that speak languages other than English. And it is a cluster randomized trial as well in sort of inpatient PHM teams. The intervention involves sort of a bundle of things to improve communication. And so the outcomes involve measurements around safety, patient experience, communication quality between the team and families, feelings of discrimination or discriminatory treatment, and then disparities across those different outcomes. And these things are measured in a variety of ways, from participant surveys to rounds observations, and safety surveillance, including direct reporting of safety events by families. And then I don't know if Kathy has Kathy joined. Hadley, I might let her talk about this. If not, I'll keep talking. But I don't see her. So Kathy Auger and I are just kicked off this trial, which I mentioned really came out of that prioritization work I mentioned at the beginning that PRIS has helped work on. A lot of the questions that came out of that were really around hopefully safely doing less around antibiotics to spare kids, families, and our communities the harms of overuse of antibiotics. So TRIAD, or the trial of reducing inpatient antibiotic durations in children, is a multi-center trial where we're directly comparing 5 versus 10 days, I think there's a typo on here, of antibiotics for the total duration of treatment for kids hospitalized with pneumonia, skin or soft tissue infection, or UTI. And we've designed this as a superiority trial, trying to incorporate all the things that matter to patients and families around antibiotic treatment. So not just treatment failure, but also symptom and function recovery and the experience of antibiotic-associated adverse effects. So our first aim is to just determine what's superior, 5 versus 10 days. And then we'll also look at specific subgroups. So we'll look at this question in aggregate across all these infections, but then for each infection separately, and then certain particular groups of interest, like younger children with UTI, for instance. And then I think Matt Pantel is here to talk about SNAC.
Yes, hello. Yes, the snack study is set to, once we go through contracting finish, set to start in January. So good artwork and logos pending. Next year we'll have, I'm very jealous of everybody else's. But the snack study is also a PCORI funded study and stands for, as you can see, Social Needs Assistance for Hospitalized Kids. And the background of this is, I think everybody in here knows that hospitalized children have high rates of social needs, and so hospitalization can present an important opportunity to screen for and address patients' social needs, and to connect patients to and families to community resources to address those social needs. And many organizations endorse screening for and addressing social needs during hospitalizations, but actually, there's not a lot of evidence about what the best practices are that are most effective to do this to lead to improved health outcomes. And from a PRIS survey study that was co-led with, I think Jana Leary is still here, that we did a couple years ago, we found that we know that PRIS hospitals reported that they're those that are providing resources to address social needs. They often use things like giving a list of community-based organizations and use things like social needs referral platforms, like people might have heard of Find Help or Unite Us, to sort of generate those. And then others use, although not as commonly, patient navigators to address social needs and sort of help connect families both in the hospital but also sort of afterwards to make sure they're connected to resources, which have been shown to improve health in outpatient settings. So for SNAC, we're conducting a multi-center pragmatic RCT to compare the effectiveness of what we're calling passive referral, which is sort of generating a list of resources from one of these referral platforms called Find Help, to that'll be one group, versus having that and a navigator connect families for over the next 3 months, and trying to follow up with them and see if they could connect to resources. And so we're doing this at 6 sites across the U.S. Memorial Hermann and Texas Children's West Campus in Houston, then CHOP's King of Prussia campus, and then San Francisco General, Benioff Children's Oakland, and Benioff Children's San Francisco in the Bay Area. And yeah, working with several people I see on the call, and SUNY's co-I, and we have Bella Doshi and Nora Pfaff, who are part of our local prize membership. So yeah, excited to get this going. And if anybody's interested, please reach out. But yeah, and also I just want to say this was a great example of doing a prize sort of survey that sort of got the data that helped to make the case for sort of practices that were happening and leading to sort of helping get the PCORI grant. So very grateful for Prize's involvement.
Great. Um, and then I think, yeah, Kathy's here, so I'm going to hand off to her to talk about some of the grants we have in development, which you all might, if you join the listserv, hear about and be able to participate in as site PIs.
Yeah, hi everyone. I'm Kathy Auger. I am a hospitalist in Cincinnati and work with SUNY on PRIZE. We are really excited about some of the upcoming grants that we are working on, or have some of these grants have already been submitted. The first one is Aspire, which is optimizing antibiotic duration and spectrum for children with medical complexity with pneumonia. And that's Chris Russell and Karen Wilson that took the lead on that. I know that Jill Cotter and Mike Chu are working on the timing of IV to PO antibiotic transition in children hospitalized with pneumonia. Um, Derek Williams is working on the association between antibiotic duration and antibiotic resistance. So it's a little bit of an extension off the Triad grant, trying to decide whether or not the 5 versus 10 days might actually change antibiotic resistant patterns in children. And then improving diagnosis of UTI in children with spina bifida. Katie Forrester has been working on that for a good chunk of her career, but also looking at the triad population, or at least other UTIs that are not in the triad population. Sorry, I misspoke. And then finally, Kavita Parikh has been working to develop a grant using telehealth technology to improve safety in hospital discharge. So I think really what we wanted to share with this list is just sort of showing you the range of things that Prize is interested in. It's everything from, kids coming in the door through the ED or through a direct admission to their care during hospitalization and then getting them home safely. And so our interests are broad, and there's a lot of different opportunities for people to be involved. And probably the best way to be involved is through the listserv and trying to hear about our projects coming out. And then if there's something that excites you, you can reach out to the PIs directly. Suni?
And then I think we had a couple more in the pipeline that, and Elisa couldn't be here, but sent this last slide of things she is working on, focused on extending the work of patient and family-centered IPAS to subspecialty teams where it's currently been really focused on hospital medicine. And this is a more implementation-focused study that they're putting a grant together for, again, for PCORI. And then I think potentially on a little bit later timeline, thinking about extending IPAS, patient and family-centered IPAS work to pediatric ICU settings as well, knowing that these contexts are really important and different, and these workflows might need to be adapted to work how they have in hospital medicine. So I think our last slide is just, again, as Kathy was saying, a reminder that the best way to get involved with these studies, to hear about the PHM research you heard about here, to access our services, if you want help with your own research, is to just sign up to be on our listserv, go to the website and poke around if you want to submit an idea. It is really quick and easy. And then if you do want to find out again if your site is a part of PRIS, you can email Hadley, and we update the list of sites on our website periodically as well, so you can check there. But for now, you can email her because we're actively updating that. So with that, I'll pause. I know folks have been putting questions in the chat because we did a lot of talking, but feel free to unmute and ask any questions you have. And I don't know if Pat, Chris, Kathy, or others have anything else to add to. Feel free.
Yeah, I think, can I add something soon? Is that okay?
Of course.
Yeah, no, I just wanted to, first of all, thank everyone for joining. It's like the turnout is really amazing. And, um, and part of my role on the steering committee, we're actively trying to think about how we can engage, um, a variety of different sites. And we know that there are sometimes some barriers to being able to participate in our projects. So, if anybody, has had some barriers in the past or is anticipating barriers, please don't hesitate to reach out to me, and I'm happy to help think about how to navigate those. We're also trying to figure out how one of our other missions is to help junior faculty and fellows and early career faculty who may be interested in having sort of a more research focused career. So if there are fellows or junior faculty at your institutions who have expressed interest in that career path or potential career path, please don't hesitate to have them reach out to myself or anyone on the PRIS Executive Council or Steering Committee. And we want to make sure that we know about them so that we can invite them to our meetings or our events and help support them in what is a challenging pathway, but also a really rewarding one.
Thanks, Chris. So there's a couple questions in the chat about being a site PI. So I'm seeing some chatting, but in terms of the work that it takes to be a site PI and then roles in terms of study design and authoring manuscripts. Eric, do you maybe want to answer that from an I-Decide perspective, since that's a pretty large study, and then either Suni or Kathy maybe from a triad perspective?
Yes, happy to, Hadley. So let's see. I decide, yeah, is different than I think some of the other grants in that we've specifically designed it so it's not meant to be a huge lift for site PIs. For example, all of the data, like, and feel free to reach out to me if you want more details about this. But by and large, the consenting of patients into iDecide, the data collection for iDecide at most institutions will be done centrally in Seattle. And so there are exceptions to this, but for most site PIs, the main task is doing chart review of folks who are eligible. There's a small financial payment that goes to sites for each phase of that trial, and opportunities for authorship, absolutely. And then we also recently learned that we can give MOC credit for participation as well. Hadley, were there other things I was supposed to answer?
I think that covered it.
Okay.
Yeah, I may just a little bit more generically. So, the way that we aim to do this at Prize for the big studies of which I decide is a great example of one that's relatively light touch for a site PI. I would say Triad's an example of one that has a fair bit more ask for a site PI, and Kathy or Suni can maybe speak a little bit more to that. But what we aim to do is put out calls to our listservs and then have webinars so that we can share study aims, what the specific asks are of the site PIs. Because of course, for all of us, probably there would be times when site PI would work really great, and there are other times when we're just kind of at capacity and wouldn't be right to say yes. So we will aim to make that clear, and we'll also aim to make grant budgets as much as is possible support the doing of the work. The final thing I wanted to share is for all big grants, there also will be a scope of work document that's usually a pretty straightforward and brief form that says this is what we expect for you on the grant. It's kind of the flip side of the budget document, which shares this is what we're going to give you to help make the grant successful. So I think iDecide and emo were both examples where those things were left relatively broad so that the site PIs could figure out how to use the money to do the most good for their teams. Triad, because we need a site PI to handle recruitment, and the interventional drug study does have a little bit more precise ask. Kathy or Suni, do you want to share a little bit about that specific example?
I mean, I think as Pat alluded to, for this trial, which is a drug trial, we were looking for sites that had a relation or could have relationships with their institutional investigational drug trial group at their hospital. And then really because we're looking to recruit a large number of patients into a randomized controlled trial. We were really looking for sites who had previously done some sort of pretty intense prospective patient recruitment. And with that, again, as Pat mentioned, we are asking our site PIs to be pretty involved and meet with us regularly and help us with our recruitment across sites. But I think one thing that's popping up in the chat is like the drug trial, and this isn't a drug trial that's like industry sponsored, right? This is a drug trial that is like two links of an antibiotic that we all prescribe all the time, and so therefore it's not pharma funded, it's PCORI funded, but like those trials are very large, and that is like the tip of the iceberg of what PRIS has done. Like historically, PRIS has done a lot more in the way of understanding variations in practice, understanding capacities at children's hospitals. We are very excited to support people who are thinking about writing a K and maybe are looking for collaborators and connecting people that way. So there's some information in the chat about like survey studies are very common that we facilitate. We facilitate sometimes multi-site chart reviews, those kinds of things too. So I don't want you to think like, oh, well, I don't know how to do a drug trial. Well, neither did I a decade ago, right? And it's been a learning process of my career to get to this point. And so we aren't expecting people to have already had a decade of their career focused on research. We recognize that many of you are clinical hospitalists who have an academic interest, and we want to partner with you.
Yeah, so I think as a site PI, the commitment can range anything from filling out a survey to doing chart review to prospective data collection to recruitment and setting up all the needed local infrastructure to do that. And the main PIs, when they put out the call for things, will try to be as clear as they can about where along that continuum you would be as a site PI. And according to that continuum, there'll also be variation in co partnership in study design or designing ancillary studies or authorship. But we also, again, just to emphasize, like any type of research you want to conduct, the network can be a great partner too in figuring out resources, connections, collaborators, etc. We caught up on the chat questions. I think we've answered most of them. All right. Well, Hadley mentioned, I think, in the chat, but we will distribute the slides and the recording of the webinar. I just want to thank everyone again for their interest and time joining today. We would love to work with you. And I hope everybody has a great afternoon. And you can feel free to reach out via the website and those channels with follow-up questions as well.
Bye. Thank you.
Thank you, guys.
I don't see any more questions. I will go to